Right, fine. Oh, here we go. So this is what happens to me on a Friday afternoon. I finish my clinic and I feel like death warmed up. I need a couple of pints of beer or something to keep me going. And I get a call from the hematologist. I'm sorry, so, but this is what happens. And I get a chest x-ray on the screen, and it says this, and the patient's a couple of weeks after an allograft, they've got a high fever, they're hypoxic, they've had their tazocin, they've had the Caspo. What do we do next? And that is a good question. And what I'm going to try and do today is give a feel largely for the clinical assessment of these patients. The clinical assessment is very helpful. People can get a little bit nihilistic about the fact that there's so many different pathogens, so many different problems that are causing this. I think that the clinical side of things is not that relevant, but actually I think it's actually much more relevant for these patients, and perhaps the investigation potentially. Anyway, so I'm going to talk about how we approach the situation, what tests can be used and what they can give you, and I'm not really going to talk about empirical therapy too much. I'm here for half an hour. So this is the problem. The problem is that when you've got somebody, this doesn't work, does it? With a community-wide pneumonia at the top end there, they've got somebody young with pneumonia, they have a pneumococcus, maybe they're very lucky, a Staph aureus or something like that. Older people on steroids, been drinking a bit too much, or have been exposed to chemotherapy. Then what we might call the environmental pathogens, such as Pseudomonas and Legionella, become more likely. But in the patients that I look after from the hematologists, we're at the bottom end of the spectrum here, and then a whole bunch of different pathogens become an issue. And we can divide these into 3 or 4 main categories. One, fungal pathogens, Aspergillus or Pneumocystis. Now, they're very different in the way they present, but they're both fungi. Respiratory viruses, these are the normal things that we've all been suffering from for the past couple of weeks, the influenzas, the RSVs, the metapneumoviruses. But in somebody whose bone marrow has been replaced by somebody else's bone marrow, they get very prolonged and more aggressive disease than we do. So you would say that's a more aggressive disease of a common condition. And then there are things that we all harbour within ourselves potentially, such as CMV, which most people would probably be exposed to and probably have integrated in the genome somewhere. A TB, maybe fewer people in this room have that, but it depends where you're born. These things, like it when you're immunosuppressed, become activated and can become a potential problem. So you can call it the triumvirate of evil. Aspergillus, CMV, and PCP become the major questions that you have to think about with somebody who's severely immunocompromised. And I do mean severely. Bone marrow transplant, a lot of steroids for a long period of time, somebody's been anemic, aplastic anemia for several weeks, etc. Or the SCID is one of the many forms of primary immunodeficiencies. I'm not going to talk about HIV, but it's sort of relevant for HIV as well. Okay, so that's what we're looking at. And the bugs can come from reactivations, as I just mentioned. CMV, Pneumocystis actually is a reactivation disease. Pneumocystis is a very unusual fungus, and that it seems to live in the human lung. That's its normal place. And it doesn't cause problems unless you have a very marked T-cell defect, in which case it can start replicating, and when it replicates, it causes an inflammatory response, and that makes you hypoxic because you get an alveolitis. There are unusual organisms, histoplasma, coccidioidomycosis, which I keep mentioning because I get very excited when I come across a case, but it isn't that uncommon to come across a case of potential endemic fungal infection. And these patients are people who've lived somewhere abroad where the fungi are endemic, they've inhaled them, and like TB, it's latent disease, and like TB, it can be reactivated. So those do occur, and you need to think about them, especially if you've got an American on the allograft ward. Okay, nasopharyngeal commensals. This is the source of those resistant gram-negative bacteria, the Pseudomonas, the E. coli, that you need to give people horrible antibiotics for to kill. When you've been in hospital for a while, the oropharyngeal floor gets replaced, and it gets replaced. Sorry. Oh, are you filming? Yes. I haven't realised that. So I keep moving out the shot behind the podium. Sorry. Okay. I thought you were getting very excited by the talk rather than...
We're getting very excited.
So you have antibiotics, somebody's in hospital, they get the flora at the back of their throat gets replaced by these resistant gram-negatives. They slide down into your lung, and you get a pneumonia, and that's why you get a pneumonia for something that requires meropenem to kill it. And then there's the environmental organisms, which is largely Aspergillus. There are some rare other fungi that can be a problem, Nocardia and non-tuberculous mycobacteria I'll touch on briefly. Where you inhale these things, everyone inhales Aspergillus the whole time. I mean, it's ubiquitous. And most of us have an immune system which fights that off. But if you don't have an immune system that fights that off, you will get an Aspergillus pneumonia. Occasionally, I'm not really going to talk about this, you can get blood-borne spread from an indwelling line or a catheter, which is colonized by Candida, one of those resistant gram-negatives or gram-positives that I mentioned earlier, and they will cause nodules in the lung. And then there's respiratory virus, droplet spread. You inhale these, you go home, and unfortunately your sister visits you, and she has a coronavirus that's causing a mild cold, sneezes on you, and bang, you get a respiratory tract infection with that coronavirus, and you're in trouble. These are very important because if you put somebody with one of these on the open ward, it's not good. It can spread, and that is bad. Now, I've talked about bugs, and there's quite a lot. The problem, of course, is that these patients don't just have bacterial, viral, or fungal infections. They can have non-infective causes of their lung changes. And that varies from the standard stuff, pulmonary edema, very common, ARDS. They can come in with an infection somewhere else and then develop bilateral alveolar shadowing, and that would be ARDS. That's relatively common. Or it could be less common things, drug toxicity, organized pneumonia, something called idiopathic pneumonia syndrome, which is essentially what it says on the tin. We don't know why they have an alveolitis. Occurs after bone marrow transplant. Radiation, less so nowadays, but still possible. There's a mixed bag of rarities in the hematology background patients, diffuse alveolar hemorrhage, Grafton syndrome, metastasis, veno-occlusive, lymphoproliferative. They all have their own little patterns, clinical patterns, but need to be considered in certain circumstances, although they're relatively rare. And there is pulmonary graft versus host disease, which I don't think I'm talking about today. So, okay, if you're going to talk about the pathogens, what's the relative frequency? Well, bacterial pathogens probably make up about 40%. Gram-negatives and gram-positives, relatively evenly split. These are data from a published paper, plus my own sort of add-ins. Aspergillus, about a fifth of the time. Pneumocystis, 5 or 10% of the time. Respiratory viruses are pretty common, actually, 10% at least. The unusual inflammatory conditions that I'll mention one or two of later, about 10% of cases maybe. Fluid overload is very common. It's also common even when there's another problem going on. So it's a cohabiting problem with a pathogen frequently. And then the rarer problems, well, atypicals, mycoplasma, pretty rare. CMV, fortunately nowadays, is rare. Because of the blood PCR, CMV reactivation is actually identified early and treated before you get to CMV pneumonitis in most patients. Nocardia, TB, they're relatively rare, but they do cause problems. We've had at least 3 cases of TB over the past year and a half. And the other filamentous fungi, the mucors, the scedosporiums, they are nasty things, and they're very hard to pick up. Right, so the tests that we do, and this is relatively straightforward. It's sputum microscopy and culture, and for Acinetobacter bacilli as well, if you're worried about mycobacterial infection. Blood cultures. You can do the pneumococcal and Legionella antigen. That's not going to be terribly effective in people's immune systems when it's been completely flattened. But later on, it can be useful when the immune system is reconstituted after a stem cell transplant. The CMV blood PCR is very useful in certain specific circumstances. And the nasopharyngeal aspirate for respiratory viruses, the COPAN, is a brilliant test. And it's very useful for diagnosing respiratory viruses, and it is very handy from that perspective. I have to say, I have very little experience of galactomannan or beta-glucan antigen testing, both of which do have a use, but has not been available in my hospital for most of my practice, but it's become available, and we're beginning to get a feel for it now. But if you want to diagnose PCP, CMV, or the fungal infections for short, you need to do an invasive infection. And there's 2 types of invasive infection. One is a bronchoscopy, which is where you're trying to get a large fluid from the bottom of the lung, and you can send that off for cytology to look for fungal hyphae, AFBs, virology, culture, again, PCR, culture for bacteria. Well, you can do transbronchial biopsies. They're not terribly good, and they're very dangerous. There are newer things coming in, stereotactic biopsies and cryobiopsies. I think there's some discussion about that in the program, isn't there? So I'm not going to really talk about them, but those do potentially have a role, but at the moment we're not quite there yet. But the alternative test to a bronchoscopy, which is useful in very specific circumstances, but in those circumstances incredibly useful, is actually a percutaneous CT guided biopsy. And that's particularly good for macronodules, and I'll show you that later. The ultimate test for lung disease, where you haven't got a clue what's going on, is a video-assisted proctoscopic lung biopsy. We use it very rarely. When we use it, we're desperate, and I don't know about here, but in our hands, it doesn't work out well for the patient. When you're in that situation, they don't survive. So one of the questions we have to think about is when to use these invasive tests, and I hope I'll give you some clarity on that through the talk. Right, okay, so that's all the bad news. Good news. The pathogen is dictated by the immune status of the patient. The immune status of the patient is dictated by their disease and by what has happened to them. Hence, you know which pathogens they are most susceptible to, just by the clinical history. The pattern of the presentation on the CT scan tells you what the most likely pathogens are going to be, and that's the basis of most of this talk. And the clinical clues are very helpful. Again, that's the basis of most of this talk. And using a combination of those clinical assessment, CT assessment, knowing the background of the patient, you can target your diagnostic tests and don't have to do everything in everybody. And actually, when you are managing these patients, I don't have to tell you exactly what the problem is. What I need to do to manage the patient effectively is tell you what treatment options are the most optimum for the management of that patient at this time. Sometimes we know exactly what's going on, but often it's a question of deciding between which of the very large range of empirical therapies you should be using. Okay, so pathogens are specific immune defects. I'm not going to label this too much, but largely it breaks down into, if you have a neutrophil defect, then you're going to worry about aspergillus, as well as bacterial pneumonias, occasionally the rare filamentous fungi. If you have a T-cell-mediated immunity, then you worry about pneumocystis, the CMV, and the respiratory viruses, and in certain circumstances, nocardia and mycobacteria. Steroids does everything, as a sort of general rule of thumb. Immunoglobulin deficiencies will open you up to bacterial infections and respiratory viruses. So, CT patterns of disease. We can break these down into four. There's consolidation, which is dense alveolar shadowing, like that. There's nodules. That is a macronodule. It's bigger than 3 centimeters, rather than a small nodule. Ground glass infiltrates, which is bilateral in this case. And that's triated bud, which is the most beautiful CT appearances. And normally, in these circumstances, it means a respiratory viral infection is present. So those are the four patterns. Now, with that, you can also overlay that with the speed of onset of the problem. So, bilateral alveolar shadowing that comes on rapidly, you think about pulmonary edema, ARDS, pulmonary hemorrhage in the right circumstances. But if it's coming on more slowly, then you worry about PCP. For example, somebody who develops lobar consolidation that develops over 2 or 3 days, high fever, CRP, bacterial pathogens are going to be there almost all the time. But if they've got a slowly progressive consolidation, then it's slightly more confusing. So on and so on. Right. So we're going to start, and this is where I start to have some fun, because I'm going to pick on people. Right. This is a 60-year-old lady. She's 6 years after autograft from myeloma. Because of myeloma, she's had IgG deficiency for a long period of time. She's not been given replacement therapy. This is a 3-day fever, cough, shortness of breath. So a short, acute illness. CRP is 336, and there's bilateral shadowing, but fairly dense consolidation, especially on that left-hand side, a bit more on the right-hand side. Anybody know what's going on? Oh, Yeah, this is going to be a bacterial infection. She may have background bronchitis, absolutely. And that's what the CT scan looks like. Good. So somebody presents like that. Actually, you don't need to be too clever about what you want to do. You do a blood culture, you do a sputum culture, and they're producing it. And there's probably little point in doing a bronchoscopy immediately, because actually, the time you get a bronchoscopy, you're giving them 24, 48 hours of antibiotics anyway. So these patients would normally get empirical antibiotics, and which one you give them depends to a certain extent on the background of the case and what pathogens that you know are relevant. So it depends whether they're community-acquired or hospital-acquired. So she had a sputum which was positive for Haemophilus influenza and got better with coamoxiclav. Fantastic. Okay. So, rapid onset, blood culture, C-reactive protein, very helpful. They've actually stopped doing them in the haematology ward of my hospital, which is making life more difficult for me. Because if you go from 0 to 300 in the space of 3 days, then there's a pyogenic bacterial infection present. Start the first-line antibiotics. Now, the issue comes when it doesn't work. You give them whatever antibiotics, your first-line therapy, and they're not better. Then you have to think about which bacteria you're not killing. And that comes down to the resistant gram positives, so MRSA, for example, mainly MRSA, not many others. Resistant gram negatives, is it a Pseudomonas or an Acinetobacter, and they're on Augmentin, which is not going to work, therefore they need to go to Tazocin. Or actually in our hospital, if they're on Tazocin, it might be a resistant gram negative which has been exposed to Tazocin and there's resistant, and you might have to get the meropenem. And just bear in mind, anaerobes are an issue. Most of our broad-spectrum antibiotics will cover anaerobes, but just double check. So if there's no response, swap the second-line antibiotics and think about getting the bronchoscopy, because then you might need to know what the resistant organism is. And if it is a resistant organism, the bronchoscopy to get a lavage for culture of bacteria is helpful. Okay, now I'm going to ask Hannah. Hannah is a clinical lecturer in spiritual medicine, and I always pick on Hannah. This one is a little tricky. So this is consolidation that occurs, but it's much slower in onset than the previous case. It's 2 to 3 weeks. The patient's sort of grumbling along, getting a little bit worse as time goes by. Low-grade fever, breathless. More breathless than perhaps you might expect with the degree of consolidation you can see on the CT scan. So, and we've given them every antibiotic you can think of, and they're not getting better. Cultures are all negative. And there's the lung function. So, Hannah, what would you do next?
Call you.
Lung biopsy. Okay, so lung biopsy is how you make the diagnosis in these circumstances. And there's 2 types of lung biopsy. There's CT-guided biopsy and there's VATS biopsy. To do a CT-guided biopsy, and you can do it for this disease in some circumstances, what you need is something like this, which is dense consolidation against the pleura, preferably. Because then when they do the biopsy, it does not traverse the lung, the chance of pneumothorax is low. The problem with doing a CT-guided biopsy in this particular case is the depth of that consolidation is relatively thick. And I don't think we need a CT-guided biopsy in this case. Where's the radiologist? What's this? Okay, right. Yeah, this is an organising unit, like 9 times out of 10 is organising unit. And it's peripheral dense consolidation, bilateral, relatively symmetrical. You give them steroids and boom, boom, they're better. So the diagnostic test in this lady should be a CT-guided biopsy, but it's not possible. VATS biopsy is a bit heavy. Give them steroids. If they get better, you're right. Now, what I'm using this to illustrate is that the CT pattern is very important because it gives you a clue as to what's going on. Sorry.
Can I ask how quick would you expect the response to steroids? Would it be, say, 24, 48 hours, or is it something that's
No, so that's a big problem because what you have is consolidation which is barely visible on a chest X-ray, and you need 2 to 4 weeks of steroids to get better.
But I'm clinically, not radiologically.
Oh yeah, so the patient gets better in a few days. You start the steroids and they start to feel better, the hypoxia will get better, and they will get better clinically. And then to prove it, you need the radiology.
So you have a fairly rapid response. Because what I'm saying is, if you see you looking at the patient and if you've seen that response fairly rapidly, that you're fairly confident. Although I suppose you were saying really logically fairly confident to diagnose in the first place.
I'm relatively confident because this sort of weird symmetrical subpleural pattern doesn't occur in pathogens, right? You may want to do a bronchoscopy just to make sure that you're missing something. It depends on how clear the CT pattern is and, I guess, how confident you are clinically. So this is a case of organised pneumonia. It gets better with steroids. That is proof of the diagnosis, essentially. And it's here we go. So subacute consolidation is much more tricky than acute consolidation. And it can be a bacteria. It could be Aspergillus nocardia. It depends on the extent of the shadowing and the shape of it. Organised pneumonia comes into question. Disease relapse of lymphoma can cause consolidation patterns on the CT scan, which is a concern. And I have seen infiltrates with other hematological diseases, CLL, things like that, which is not common, but it does happen occasionally. So the pattern of the CT scan really is important here, and this requires a bit of consideration and discussion with the radiologist about what to do. But diagnostically, it's sputum again, culture, AFB, cytology. Don't ever forget cytology. Bronchoscopy for the lavage, again for cytology as well as culture, and the galactomannan if you have it available. And then if you've got consolidation which is like this, your radiologist can do a biopsy. And that's diagnostic, you hope. And then if you're really desperate, as the man said, VATS biopsy is the right way to do it, but if we can avoid it, we would, because the chance of complications in this patient background is high. Okay. Oh yeah, right. A non-respiratory, non-radiology doctor needs to volunteer for this one. Sorry? Okay, so the first question is, what's abnormal in this chest x-ray? This is a young lady with aplastic anemia, neutrophils been flat for a long time. Oh, somebody's pointing, yeah? Yeah, so this is the sort of thing that the chest physician and radiologist sees instantly. Medical students don't ever see, but, you know, fine. And that, if you do a CT scan, looks like that. So the lady who saw that shadow, what do you think that might be? So I would describe this as a macronodule. It's relatively round, as you can see the mediastinal pleural, which is why it's not completely round. There's a bit of a halo around the edge, which is meant to be diagnostic. And she's a lady who's had neutrophils which have been 0 or 0 point whatever for several weeks. So this is going to be, anybody? Sorry? Yeah, this is Aspergillus. This is Aspergillus. Yeah. 9 times out of 10, this is going to be Aspergillus. So, how do you get the diagnosis? Sorry?
CTPA. We hadn't talked this morning about
CTPA. Okay. Bronchoscopy is a 50% diagnostic test for these circumstances. I don't know about galactomannan. I haven't got enough practice. I mean, the answer is actually, you don't need a diagnosis. This is Aspergillus. It would be nice to know for sure, because they're not getting better, then it could be a non-Aspergillus fungus, and then you're in trouble. So if you can get a biopsy, which is my preferred method of diagnosis, tell me about the CTPA then. What's that? How do you know it's Aspergillus from that? Is it?
So, that is a long...
I was in clinic.
Considering Aspergillus infection are angioinvasive, we search for the interruption of the vessel inside the lesion.
Okay.
And we found that around 100% of the patient with not only Aspergillus, let's speak about the invasive mole disease, have this sign, the vessel occlusion sign, while if you don't have a fungal infection like virus infection, bacterial infection, lymphoma, GVHD, BOOP, the vessels are completely normal inside the vessel.
Okay.
The lesion. This is this.
So actually we put a needle into this one. If you do a CT-guided biopsy of a macronodule, it's going to be diagnostic in 90-95% of times if it's aspergillus, which is great. And you know, I'd be interested to see the CTPAs.
For example, in this case, I would not do the biopsy. I
Yeah.
would do the CTPA.
Instead.
If it was positive, I would not put the patient at risk of the biopsy.
So, macronodules, I'm not going to labour the point because other people are doing radiology, but what the CT looks like, hang on, sorry, this is the management. And this depends on the patient's at risk of aspergillus or not. Now, the risk for aspergillus is largely steroid neutropenia. It's not entirely. You could get other patients will have aspergillus on occasions, but the high-risk patients are the ones with neutrophil defects or on high-dose steroids. You can do your normal cultures, you can galactomannan antigen. I like percutaneous biopsy, or we can do a CTPA now. Lavage is not terribly sensitive, and I don't know the benefit of galactomannan on culture, but culture itself is very poor. But often, if the CT is classic and the patient is not well enough to test, we will just treat. And the problem occurs if the patient isn't a classic risk patient. Then there are other causes of macronodules, such as myocardia and mycobacteria, which might come into the equation, and I'll be much more keen to get a diagnostic test, bronchoscopy and or a biopsy. A bronchoscopy, because you can see nocardia and mycobacteria much better than you can aspergillus for some reason. Okay. This is the evolution of the appearances. Macronodule with halo, there's two there. Then as you treat or the patient's neutrophils recover, it becomes much more circumscribed. And in the middle, we have an automycetoma occurring where the fungus has destroyed the lung, and you get a nice little round ball, and then eventually it forms a scar. This is the one on the left. You can see a very thin wall cavity. The one on the right is a thick wall cavity, mycetoma in the middle, and it's a bit unclear whether that's completely cleared or not, whereas the left-hand one is so thin-walled, and there's nothing in the middle. That fungus is gone. This is important because if you come along and give this patient heavy-duty chemotherapy or transplant them and don't give them fungal prophylaxis, that reactivates. Okay. I'll miss this one out because of the basis of time. Diffuse lung disease. Now, this is the problem. This is the really difficult area because there's a bunch of different diseases. They're all different, and they all require different therapy. And there's a whole bunch of non-pathogen diseases you have to bear in mind. So, the things you worry about, pneumocystis, CMV, respiratory viruses, largely T-cell defects, but not exclusively. If it's neutropenia, they can have a sort of widespread pyogenic bacterial infection. But there are non-infective causes: ARDS, idiopathic pneumonia syndrome, pulmonary edema, alveolar hemorrhage, drug toxicity, organized pneumonia, not quite this sort of pattern, but other patterns. The good news, aspergillus, nocardia, mycobacteria are much less likely, so you don't need to worry too much about those ones, which takes a whole tranche of the treatments that you could use as unnecessary. So, how do we approach this? Well, clinical background, fluid balance weight. How often I go up to the wards and I see the patient was 60 kilograms 7 days before, is now 65 kilograms, and they're breathless. That is like the easiest diagnosis to make. The question about whether they've got sepsis elsewhere, which might be causing ARDS, needs to come into the equation. CMV reactivation needs to be looked for. So, and the investigations, well, C-reactive protein, blood sputum cultures, clotting in platelets for diffuse alveolar hemorrhage. The CT pattern helps, and I'll give you some examples shortly. The big issue is that these are the patients I most want to do bronchoscopy on, but are the least suitable for it because they're hypoxic. And that is that's a timing issue. There's a problem with these patients is because they can go from being relatively well to being grossly hypoxic in a few days, and the bronchoscopy needs to be done before they get the gross hypoxic phase, and that's tricky. It requires sort of fairly rapid assessment and moving forward with the bronchoscopy to get them before they're too hypoxic. So, I can't remember what this one is anyway. 45-year-old lady, 1 month after an overdraft, fever and cough, a couple of days, rapidly progressing hypoxia and shadowing. Oh yes, I know this is white cells of 0.6, 4 days before, and now 26. Anybody got to give me a guess what before this could be? Well, the answer is we don't know, because she never had a diagnostic test. But the white cells jumping from 0.6 to 26 were at the same time as diffuse alveolar infiltrates occur suggests that perhaps she's having an engraftment type syndrome scenario, possibly. But there's no proof of that, right? So, but that's the situation often, is that you just need to come to what you think might be the diagnosis, make sure the patient is safe with broad spectrum antibiotics, give them steroids if you think it's going to work, or just wait for things to settle down. So that's pretty much, so the acute situation is likely to be alveolar hemorrhage, is likely to be pulmonary edema, ARDS, or bacterial pneumonia, with alveolar hemorrhage and engraftment syndrome, and all these rare things, less likely. And they don't require quite so much investigation, and because of this hypoxia issue and the bronchoscopy timing, it's hard to get investigations done. The subacute is more likely to be pneumocystis, respiratory viruses, the drug toxicity, maybe CMV, the idiopathic pneumonia syndrome, still could be pulmonary edema, etc., but it's not going to be ARDS by definition. And these patients are the ones where you really have to look for the viruses, with a COPAN for respiratory viruses, CMV for see whether they've got CMV reactivation, and recently we've been doing blood beta-glucan, which actually I think is probably quite good for pneumocystis, but not that. I haven't got that much experience as yet. And these ones we do have a chance of doing bronchoscopy. The slide from being normoxic to being hypoxic and too ill to have a bronchoscopy is slower, so the chance of getting a bronchoscopy is higher, but it does require recognition of the problem relatively early. Right. Anybody know what this is? Alex. I haven't picked on you yet. So, squeaks, yes. What did I tell you about squeaks? Viruses. Squeaks equals respiratory viruses. And this is a beautiful CT scan showing tree and blood infiltration, which means there's bronchial inflammation, a bronchiolitis, diffuse both sides, everywhere, means it's most likely respiratory virus, it's D-Copan, and it's positive for paraflu-free. It's always paraflu-free, it's never 1 or 2, I don't know why. So that is tree and bud changes in the CT scan. You can't really tell from the chest X-ray that it's tree and bud. This is where the CT scan is worth its weight in gold. Okay. Viruses, actually they're not that uncommon. About 10% of stem cells have a respiratory virus infection that brings them into hospital after, and normally about 3 or 4 months after the transplant. There's a mixture of different viruses. They pretty much present the same way. The only difference is that adenovirus can cause systemic infection and can be very unpleasant indeed. The others are relatively mild. You just sort of dribble on for a period of time with a moderate to mild respiratory illness. The trouble is that half of them will get co-infection with another pathogen due to the virus, and there is the possibility of developing lung graft-versus-host disease as a consequence of the virus. Well, becoming apparent because of the viral infection. And they're contagious, so they fill up the side rooms. Okay. How much time do I have left? 2 minutes. Yeah? Okay, so I'll bang through this then. This is a lovely, very obvious case. 55-year-old man, autograph 6 months previously, increasing dyspnea, progressively getting worse over a period of 3 weeks, that chest X-ray, low-grade fever, not much of a CRP. What is the diagnosis? Pneumocystis. And we prove the diagnosis by doing what? CT scan. Okay, so the problem we have is that when we do large reduced sputum, it doesn't give us the diagnosis in a bone marrow transplant population. I don't know why, but that's the case. Whereas this CT scan shows diffuse alveolar ground glass infiltrates, relative sparing of the subpleural space, and the bases were clear. It's very, very characteristic. So you can treat that patient on spec. So known risk group, stem cell transplant means it's a T-cell defect. Increasing dyspnea over weeks. They present with a very tightly set, I've been getting more breakfast over the past 3 to 4 weeks, and those hematology consultants don't listen to me.
Of course we do. But we do a beta-glucan.
Yeah, well, so beta-glucan, I think, we've only had 1 or 2 cases who have used it, and if it's high, it's really, really helpful. It gives you that diagnostic certainty. It doesn't, it's not clear that they've got PCP, but that plus a CT scan is very helpful. I mean, these CT scans, something like that, I mean, that is PCP, you know, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday. There's no way to do anything else. So that's great. The trouble is, of course, that not all, I give you the best CT scans I've got. I don't give you the ones which are halfway there and not quite that, like that. And that's where beta-glucan will be useful because it is very high, and then you have the strength to go ahead. The problem is that pneumocystis requires Septrin and steroids, and both are not good for you if you don't have pneumocystis, especially if somebody's doing something to your marrow. Okay, so the threshold for starting treatment needs to be relatively high, but you don't want people to die from this disease, so you don't have to be so high that you miss it. And the problem is that drug toxicity is the main differential diagnosis, and the steroids will make that better. So you can be left at the end of the day not knowing whether the patient's got better because of the Septrin or because of the steroids treating the first pneumocystis, but the steroids can also treat a pneumonitis due to drugs. Okay, I'm going to call it a day, I think. This one's a case where you just don't know what's going on, but the CMV reactivation in the blood was so high that you would suggest that it is CMV. But to make the diagnosis, you need a bronchoscopy, but she was too hypoxic. Got better again, and that's just hideous, isn't it? I mean, I'm sorry. And that's what happens if you get CMV. That happens after CMV. This is a CMV-specific peribronchial organized pneumonia, and it leaves you with a fibrotic, crunchy lung and respiratory failure unless it gets hit with steroids hard. Okay. Right, conclusions. So, yeah, immune defect, pattern of radiological presentation, but the clinical aspects are important. Speed of onset, degree of inflammation, how hypoxic the patient is. This will give you a sort of a matrix in which to put the patient's differential diagnosis into. And then you can target your investigations and target your treatment according to that. And yeah, there are patterns which are very likely to be specific pathogens, and there are patterns which are more confused, but at least you can limit the number of potential pathogens or non-infective problems that might be causing it by judicious use of your clinical skills. But, you know, once they get to intensive care, it's everything. And you can't get past that. Thank you.